dapat magpa-newborn screening. Oh, aming baby, isa kang blessing. Kaya dapat magpa-newborn screening. Oh, aming baby, oh, aming baby, newborn screening.
Magandang araw sa inyong lahat. Good day to all. I am Dr. Carmencita Padilla, one of the proponents of the newborn screening program in the Philippines. Join me in uncovering the wonderful story of newborn screening in our country. Together, let's zoom in on what makes newborn screening a comprehensive program for every Filipino here at Newborn Screening in Focus. To ensure that newborns are truly healthy, they must undergo newborn screening, a public health program that helps determine if a baby is born with one of the more than 20 congenital disorders. Its importance cannot be overemphasized. If any of the congenital disorders is left undetected and not managed immediately, it can lead to mental retardation and even death. It was integrated into the public health delivery system with the enactment of Republic Act 9288 or Newborn Screening Act of 2004. Now part of the PhilHealth's newborn care package, newborn screening is being offered in more than 7,000 hospitals and birthing centers nationwide. It has also saved thousands of children. This educational series is intended for health professionals who deliver services for the newborn screening program. Whether you're online or offline, this program aims to enrich your knowledge in newborn screening and be able to apply highest quality service to Filipinos, especially during challenging times. We will discuss the very process of newborn screening from the moment the baby is born and into the continuing care available for newborns found positive. We will also zero in on the features and management of each of the conditions included in the newborn screening panel. We will also interview patients as well as their parents. And in keeping up to the challenges, talk over how facilities and centers managed to give quality service despite the limits brought about by the COVID-19 pandemic. This program is the newest educational platform for our newborn screening coordinators, one in every 7,200 health facilities throughout the country. We also hope that this series will also benefit the health professionals, physicians, nurses, midwives, medtechs, nutritionists, as well as students in the health professions. So take a seat, get comfortable, as you're in for quite an adventure here at Newborn Screening in Focus.
Kaya dapat magpa-newborn screening. Oh, aming baby, newborn screening.
Welcome to the 8th episode of Newborn Screening in Focus, where we'll talk about the long-term management of congenital adrenal hyperplasia or CAH. The adrenal glands produce important hormones that regulate the body's response to illness or stress, regulate sodium and potassium levels, and regulate sex hormones. From our discussion in the last episode, we learned that individuals who have CAH have a genetic problem, resulting in a lack of one of the enzymes needed to make these hormones. Ambiguous genitalia, wherein an infant's external genitals do not appear to be clearly either a male or female, is one of the clinical manifestations of CAH that may lead to problems in gender identity. Long-term management goals, then, in CAH need to address not only the medical treatment, but also the psychosocial consequences that may arise due to this condition.
Hi, magandang araw. Ako po si Mrs. Bernardino. Meron po akong dalawang CH na anak, isang babae at saka isang lalaki. Yung pangalawang anak ko po yung nagkaroon ng CH, lalaki po siya. Ngayon po, 20 years old na po siya, college na po. Tapos yung pangalawa ko naman po, yun po yung pinakabunso ko, first year high school na po siya ngayon. Sa ngayon po, dahil po adult na sila, maayos naman po yung kalusugan. Mentally, normal po sila. Nag-excel naman po sila sa kanilang eskwelahan. Kaya lang po, meron akong napansin sa kanila yung kanilang height. Maybe dahil din po doon sa sakit nila. Kami po, as parents, na pagmamanahan din ng growth nila is hindi rin po kami ganun katangkadan. So parang yun lang po yung ko ngayon, napansin po sa kanila. Sobrang napakalaking hamon ang pagkakaroon ng anak na may CAH. Unang-una, syempre, lifetime kasi na sakit na nila ito, na lifetime mo siyang imo-monitor. Lifetime mo din siyang laging ipapa-check up, imo-monitor mo ang dosage ng gamot para sa tamang edad nila, sa tamang timbang nila. So, yung mahalaga kasi yung suporta ng magulang sa iyong anak. At sa ngayon, dahil adult na yung mga anak ko, mahalaga rin na ipapaliwanag ko sa kanila kung ano yung sakit na meron sila at kung bakit sila umiinom ng gamot, para saan yung iniinom nilang gamot. Ayun, malaking hamon sa amin kasi syempre una-una financially, kailangan mong hindi lang emotionally, financially kailangan mong masustain ang mga pangangailangan ng iyong anak. Napakahalaga na magpa-newborn screening po tayo, lalo na pagkapanganak pa lang po ng ating mga anak. Kasi noong time po na ipinanganak yung aking pangalawang anak is babago pa lang po noon nagkakaroon ng newborn screening. So late detection, 3 months old bago namin nalaman na meron siyang CAH. Kaya sa tingin ko, dahil sa ngayon is mandatory naman, is napakahalaga na idaan natin sa ganung process ang ating mga anak kasi para magkaroon tayo ng early detection. Early detection is mahalaga, mas mahalagang magkaroon ng maagang gamutan para hindi na ito mauwi sa dehydration. Tapos, kasi ang naranasan po ng anak ko is na-dehydrate siya, na-confine, at muntika na po, nag-50-50 po ang buhay ng anak ko. So kung early detection pa lang po is nalaman po namin na may ganong anak, nabigyan po siya ng tamang medikasyon, tamang gamot kaagad, hindi po mangyayari yon na dumaan pa po sa 50-50, nag-50-50 po yung anak ko.
Today, we will dive into the long-term management of CAH, highlighting the different psychosocial and psychosexual issues facing individuals with CAH. Here we have Dr. Sylvia Estrada, a pediatric endocrinologist at various medical institutions, including Manila Doctors Hospital and Makati Medical Center, and currently also the training officer of the Division of Pediatric Endocrinology of PGH. Welcome back to the program, Dr. Sylvia. And our new guest, Dr. Marga May Maanyo, an expert in pediatrics and adolescent medicine practicing at the Manila Medical Center and a consultant from the Division of Adolescent Medicine of PGH, Department of Pediatrics. Dr. Sylvia, Dr. Marga, welcome to Newborn Screening in Focus. Let's start the conversation, Dr. Sylvia. Tell us a little about CAH. You know, we had an extensive discussion in the last episode, but give our viewers a summary of what CAH is.
A very nice question. No? So CAH, or Congenital Adrenal Hyperplasia, is a group of disorders that are involved in the making of steroids. And where does this happen? In the adrenal glands. So you ask, why is it important? The body needs the steroids for stress management, for sugar and glucose metabolism, for water, and to really maintain well-being. So what is CAH? There is an enzyme deficiency that prevents the full making of all these steroids. And the most common, alala niyo po, Dr. Menchit, is 21-hydroxylase deficiency, which occurs in about 90 to 95% of CAH. So yun po ang ating CAH. You do not produce the important steroids, which is cortisol and aldosterone, which will help the body adapt metabolically to maintain well-being.
Okay, so thank you, Dr. Sylvia. And if you want to learn more about CAH, there is an extensive discussion in episode number 7. And so let's go now to just the symptoms, maybe just a summary of the symptoms of the babies. Dr. Sylvia.
Okay, so I mentioned that the most common is 21-hydroxylase. So kulang sa kanila yung steroid for salt and water balance, which is aldosterone. And then kulang din sa kanila yung cortisol, which is the hormone for sugar metabolism. So kung kulang yon, what do you expect? The baby will be weak, will be dehydrated, will be parang failing to grow because they do not have the essential hormones to be healthy. But the more important symptom I think that we need to stress, Dr. Menchit, is yung tinatawag natin genitalia, ambiguous genitalia or atypical genitalia. And this occurs in yung ating mga females, girls who are afflicted with congenital adrenal hyperplasia, specifically for this 21-hydroxylase.
So Dr. Sylvia, when you say ambiguous, parang sinasabi natin, hindi malinaw ang kanilang genitalia. So is this obvious at birth?
Okay. Yes, if you have for the trained physician or the trained nurse, the trained midwife who usually delivers many babies, agad-agad din na napipick up to na parang naiiba po yung external, yung ari po ng bata. So pag dinefine po natin yung ambiguous genitalia, actually, Doc Menchit, ngayon po ang tinatawag na natin dyan atypical, meaning hindi pangkaraniwan, atypical genitalia. So by definition, ang ibig sabihin nun, yung description po, yung pagtingin po niyo po sa genitalia, hindi po siya yung pangkaraniwan. So let's describe na lang po. Sa babae po, di ba po, yung pong labia, dapat po nakadikit. Wala pong nakausli na clitoris. So pag sinabi po natin ambiguous o atypical yung genitalia, kuminsan po nakausli po yung clitoris, nagmumukha pong penis. Okay, so kuminsan parang biglang tingin, akala nyo po ay parang lalaki. Pero as you look closer, nakikita po ninyo, hindi naman po kumpleto na lalaki. Pag lalaki po, di ba po, maayos po yung haba ng penis. Pag kinapa po ninyo yung tinatawag namin in medical lingo, labioscrotal folds o yung scrotum, may laman po. At saka po, dark po siya, may mga linya, tinatawag po natin bouquet. Yun po ang typical sa lalaki. Pero kung ambiguous po, makikita nyo, malaki po yung clitoris, pero wala naman pong laman yung labioscrotal folds. Pag inangat niyo po yung clitoris, yung butas po hindi po sa dulo, kundi baka sa baba. So pag tiningnan nyo, hindi po siya sang-ayon sa pangkaraniwan natin pang-babae na genitalia at hindi rin po siya sumasang-ayon dun sa pangkaraniwan na panglalaki po. Kaya the medical term in the past and now moving to is ambiguous or atypical genitalia.
So nangyayari talaga, Dr. Sylvia, na nagkakamali ang pag-assign ng sex sa mga batang ito?
Opo, ikinalulungkot ko kung sabihin, yes, it happens and it can always happen.
So kung ito ba kailangan may kasamang ibang simptomas sa binanggit mo o pwedeng atypical genitalia lang ang presentation?
Okay. Pwedeng atypical genitalia lang ang presentation. Pwede rin samahan ng tinatawag namin na parang crisis, Lupaypay ang bata, dehydrated, parang hindi pang makagalaw, ang tinatawag namin dyan adrenal crisis. So pag sinamahan po ng ambiguous genitalia or atypical genitalia, sinamahan po ng parang sobrang lupay-pay po yung bata, dehydrated, wala pong energy. Pag tinunan niyo po ng asukal, mababang mababa. Pag tinignan niyo po, para pong tuyot na tuyot, yun po, dapat po, iisipin niyo na po, baka congenital adrenal hyperplasia. Halimbawa naman, wala naman siyang sintomas. Okay? Tapos, nakikita niyo, atypical yung genitalia. At pag nagbasa po kayo sa literature, sasabihin nila, ang occurrence ng atypical genitalia is mga 1 in every 5,000 babies. Pero kadalasan, ang sanhi ng atypical genitalia ay ang CAH. So, sometimes, you still have to find out, ito po ba CAH o naiiba? Tinatawag po namin disorder of sexual differentiation. Okay?
So in other words, Dr. Babu, you're saying that ambiguous genitalia or atypical genitalia is only a red flag for the health worker, for physicians, nurses, and midwives. And there is the responsibility now to check, what is the correct diagnosis. Before I go to the question about screening, when do the adrenal crisis usually set in? Kasi sabi mo nagki-crisis sila. So kasi ang kadalasan sa atin kung bagong panganak yan, napauwi yan within 24 hours and the health worker did not really look very closely at the genitalia, it is possible that the baby could have been discharged. So when do you usually see the symptoms of crisis?
Crisis. It can occur as early as 5 days to as late as 4 weeks.
Okay, so that's going to be very important for our viewers, no? We have coordinators, watching us all over the country, and this is really a red flag for the attending health professional delivering the baby. So in other words, this is one reason why we include it in the newborn screening panel, no? So maybe just before we go to the issue of ambiguous genitalia, can you just review our audience on the role of newborn screening in making a diagnosis for CAH?
Yes. So I totally agree with you, no? So it's very important, and I'm happy that you were able to include this condition because it can easily be missed. Number one, if the baby is a boy, and of course he will not present with ambiguous genitalia, but by doing the newborn screening, you can detect if he has CAH before he goes into crisis. So dapat na newborn screening siya, and if everything is in order, you should be able to get the results within a few days. So very important po talaga pag na-newborn screening at tinawagan po kayo ng doktor nyo o ng newborn screening center, Mami, kailangan po bumalik si baby para ma-retest o para ma-confirmatory test, pumunta po kayo. Okay? Because very important ang early detection to prevent the crisis.
Okay. So which brings us to the timing of submission of sample, no? In the earlier episodes, we talked about timing of sample collection and submission. And but Dr. Silvia is telling us the screening has to be done after 24 hours, submitted immediately to the lab so that you can get the results in the next few days. Because crisis may set in actually by day 5, as explained by Dr. Silvia, and it will be too late. In another episode, Dr. Silva, we talked about the issue of batching, batching of samples and hoarding of samples, parang sinasama-sama. Again, you cannot do that because if there is one patient there with a possible CAH, then you will miss the opportunity to give the treatment as soon as possible. There's another point that I'd like you to clarify with our viewers, because you said that 90%, we are actually screening for 17-hydroxy-17-OH in the newborn screening panel, right?
Yes.
You said that 90% of the cases are actually with this condition. So meron tayong 10% na ibang type. Can you just maybe review our audience what, the others that are not picked up by the program, because that is not what we're looking for in our panel?
Yes. So Kung naalala po ninyo, and I hope meron po kaming visual dito, yung steps in the steroid biosynthesis, hindi lang naman po isang enzyme yon. There are several enzymes in the steps that will come up with the final product, which is cortisol and aldosterone. So yung pinaka-common, yung 21-hydroxylase, yun po ang ini-screen natin by detecting yung 17-hydroxyprogesterone. So as I said, 90 to 95%, yun naman talaga ang dahilan ng CAH. Pero meron din po tayo yung second most common, yung 11-beta-hydroxylase. So ang physical appearance din po nun is hindi naman po crisis, pero pwede magkaroon ng hypertension ang bata, pwede din po ambiguous ang genitalia. Yun ang pangalawa, the next most common. The third naman is po yung 3-beta-hydroxy steroid deficiency. Yun din po ambiguous genitalia. And there are others also, 17-hydroxylase, including yung the PORD, yung oxidase. So we do not pick those up anymore in newborn screening. But what is our message for you? Even nag-negative, halimbawa, negative siya sa CAH, screen yung 17-hydroxy, pero yung bata, hindi maganda, hindi maayos ang kalagayan, then duty po natin bilang mga healthcare professionals na suriin. Bakit? Hindi lang naman CAH, di ba? So pwedeng iba pang reason, pwede namang sepsis din. So it is our duty to continue to find out what is going on.
So thank you, Dr. Babo. I think, that was a very brief and very concise explanation on the importance of the role of the health worker in doing the follow-up in this patient. Dr. Silvia, you mentioned ambiguous genitalia many times, and I think it's, maybe now we can turn to Dr. Marga, an expert in adolescent medicine, to share with us, the issues of a patient with CAH. So Dr. Marga, welcome again. Tell us something, on your role in the management of CAH patients, Dr. Marga.
Thank you for the question, Dr. Padilla. So basically, your children with CAH, they actually grow up into adolescents and actually later on adults. Basically, when we see them actually in our clinics already in adolescent medicine, they have already been diagnosed at a younger age with ambiguous genitalia. They were advised actually to actually work this up, but because of financial constraints, they are able to comply. They only come back in our clinics when they are really worried that they are not developing as in comparison to their healthy counterparts. That's why most often we see them, they're really concerned at this point. So it's important to discuss at this point their issues as teenagers with CAH. So basically we have to know that during adolescence, this is a period of rapid development. This is usually the age range between 10 to 19, wherein they experience rapid growth. Ito yung pagdadalaga or pagbinata. They experience growth spurt. They also experience developing the secondary sexual characteristics. Also, there's this brain development. They also develop emotionally, psychosocially, and also cognitively. So basically, these teens with CAH, they are first and foremost teenagers or adolescents. So they experience the same issues as their healthy counterparts. So basically, they have the same tasks as their healthy counterparts. They still have to develop they have to develop their mental capacity. They have to develop independence from parents. They also have to adapt peer codes and also establish a self or identity different from parents. So now these teens with chronic conditions, including those with ambiguous genitalia or CAH, they actually have more issues they face, or some issues become highlighted because of the chronic conditions and the limitations it places on their self. So basically, there's adherence to treatment, like I said a while ago, because of their lack of, they actually are most often lost to follow up because of financial constraints. That's why there's usually a lag period from the time of their diagnosis to the time we see them again at the teenage years. There's also the issue of school education. Some of them, because of the treatment, they have to stop schooling. We actually advise them to continue schooling because at this point, school is a very important source of support for them. There's also the issue of sexual and reproductive health care. There's always the issue of fertility that has to be addressed as the teen becomes older and they become more thinking about having a family of their own. There's also engagement in health risk behavior. Basically, these teens with chronic conditions, because basically they have this more drive to feel more normal. That's why they engage in smoking, drinking, and also in sexual behaviors. Also, as is a transition to adult healthcare, which I can elaborate on that later on. But important to talk about is the issues, particularly of those with ambiguous genitalia. So basically, up to adulthood, some experience a dissatisfaction with the binary gender. So basically now, either male or female ka. But now they're not satisfied with even with being labeled male or female. That's why they have issues with this point. They are actually also dissatisfied with the DSD terminology. They fear devaluation. They actually have negative body image. They also have social isolation. I remember a patient during my fellowship, this patient actually was assigned a female gender upon birth. But as he grew older, he felt more male. The issues he came up with when I talked to him at the teenage years is he felt bullied at school because he felt more comfortable going into the CR of the males instead of the females, but his male classmates would tease him. So this is an issue one of the psychiatrists on board in the team had to address. So aside from this, they feel non-entitled to relationships. They have preoccupation with heterosexual intercourse. They have difficulties in sexual function. They have barriers to communication to significant others, and also they have dilemma in experiencing the corrective surgery. So these are issues that are faced by the older teens already up to adulthood. So basically, these are the issues that these teens have to face.
Okay. So Dr. Margaret, so basically what you're saying is that there are so many psychosocial concerns by the time they get to the age of teens. So I will go back to Dr. Babu now, because if let's discuss, let's spend some time on the management of ambiguous genitalia per se, when is the best time? Because the issues that Dr. Marga were presenting were basically they grew up actually with the ambiguous genitalia. Can we address this at a much earlier age so that we don't have to go through these issues? Dr. Sylvia?
Yes, I think a very important question, no, Doc Menchit. A lot of these issues, first of all, biologically speaking, while the baby was in the womb, depending on how severe the congenital adrenal hyperplasia is, there was already an increase in your adrenal androgens in utero that already actually affected the brain. They call it brain sensitization. It's just like in males with a Y, there's testosterone produced, and in utero, that testosterone already actually affects the brain development. Now, similarly, the theory is in the very severe CAH in utero, because you don't know, right? Unless you do prenatal screening for CAH, you don't know that maybe that growing genetically female fetus is already there's already some hormonal stimulation in her brain that towards the masculinization. Now, having said that, there's nothing really much we can do about that. But at birth, at the time the ambiguity or the atypical genitalia is detected, there actually should already be a multidisciplinary team on board.
Yeah.
Definitely, even the surgeon is called so that the family, there is like a plan that is made for this child. So definitely we need to know what is the genetic sex. And then among the discussion will be, okay, this is CAH. If we actually manage properly, there is proper monitoring, and there is also collaboration with the different subspecialties. Like as the child is growing up, there will be questions about, why does my private part look different from my cousin's? So even those should be addressed by the mother. The mother and parents, the family should be comfortable with saying, yes, you are female, but you have this condition that made it look that way. Then, little questions like, are you bothered by it? And by probing a little bit, then there can be the decision to refer to a child psychologist or to a child psychiatrist so that these issues can be addressed early.
I'm really glad that you mentioned the role of the multidisciplinary team, because the problem really started from birth. And identifying the people who will make a difference in the life of that baby is going to be very important. So my question now to Dr. Sylvia now is, assuming it's a female presenting with, an enlarged clitoris looking like a small penis, will your management, for the benefit of our viewers, will your management be able to improve that condition, or will there be surgery along the way?
Okay. Normally, right now, there are two schools of thought as to when you should actually do the surgical correction or surgical reconstruction. So one school will say, you have to wait for this child as he gets older so that he can participate in the decision of how he wants it corrected. That is one school of thought. But the other will say, if the physical look of the genitalia is very bothersome, even to the parents, then maybe a partial correction or partial reconstruction will help. Even in the the mothers, the family's acceptance of the condition. First, because it's a shocker, di ba? My baby has CAH, ano yon? So they start thinking of all this. And then mga, naku, bakit ito ganyan pa? So parang feeling nila they're so overwhelmed by all these conditions. So if based on the discussion with the psychologist, psychiatrist, the surgeon, the geneticist, the endocrinologist, the pediatricians, and the family, outlining to them, if we do surgery now, this is what we expect. It's going to be a first stage. When she gets a little older, depending on the control, we might need to do a second corrective surgery and a third. So based on all these factors that will be discussed, then a proper plan can be made. So yung surgery talaga is something that has to be fully discussed and not right away, okay, I want it done, that's it. But I think it has to be a team decision in what is best for the family and for this baby.
Okay, so I have a question now. I'm happy that we're talking about a multidisciplinary approach, and this has to happen very early in the game.
Yes.
Right?
And many times, not only one.
Many times, yes. So which means even as soon as a diagnosis is made, you're saying that the attending physician, whether it's a nurse or at this point, may doctor ka na eh, okay?
Yes, yes.
You have to remember that, the nurse and the midwife may be involved in the screening, but once you have this problem, you really want an endocrinologist on board already. Okay, so malaki na yung team na binabanggit mo eh. And but I have one question, and I'm glad that we're emphasizing that if a patient has a diagnosis of CAH, you have to bring in that team as soon as possible. So I have a question for you, Dr. Babo, because I think Dr. Sylvia, for the people in the audience, we have just the names, Dr. Babo and Dr. Sylvia, okay. But Dr. Sylvia, and I think this is an implication on, the future, it's about the birth certificate, okay? So you have a patient with a ambiguous genitalia, and then what would you advise now our health workers? Will they register immediately, or will they wait a while for the diagnosis to be made before applying for the birth registration? Because I think this is something that's going to be very important for our audience.
Yes, I think we have been advising that when you see a typical genitalia and you are not sure about the diagnosis, you defer. You can actually talk to the parents and say it is best we wait for the laboratories to come in, the chromosomes to come in before we make a decision as a team as to what is the sex of your baby. So defer is what we would strongly recommend.
So if I may ask the follow-up question now, when you say, do you follow the genetic sex, or you take everything in consideration? Because usually what we do when we have an ambiguous baby with ambiguous genitalia, we go for the chromosomal studies. to tell us whether it's an XX or XY. So in the cases of CAH, do you follow the genetic results, or you consider many other factors?
Many other factors will be considered, because at the very extreme, the external genitalia may actually appear like that of a male, where you already do not recognize the labia, where the clitoris has gone really, really big. And when you do the ultrasound, even the uterus is really almost like a vestige. So there has to be many, many factors. Typically, we will say, follow the genetic sex. Okay? It's simpler because they will not have testes. Okay? And in our culture, for some reason, very important, if you are a male, you better have those testes, and you better have that. You better have the procreation capability. So you know that you don't have the testes, right? So more often than not in CAH, they follow the female sex, except in cases where I think very extreme, and which is more, it's really rare, then they would probably do a multidisciplinary decision on that. But from my experience, Doc Menchit, more often than not, the cases that we've seen locally, at least from my personal experience, thank God, are not that severe enough for us to actually do a drastic change to make them male.
Thank you. So, well, you've heard from Dr. Sylvia the importance of a long-term care and, management for these patients. And at one point, we will have an adolescent pediatrician coming on board. So I'm going to ask Dr. Marga, how soon do you want to be engaged? And how do you handle transition? I'm just talking now about the psychosocial components. I will be asking Dr. Sylvia later about transition of care for adults with CAH, but then on the psychosocial part, when do you think is the best time that an adolescent pediatrician is on board? Dr. Marga.
Thank you for the question again, Dr. Padilla. At this some point, I think we have to introduce the concept of puberty even before they actually undergo it. So basically, when I think it's best to start intervening at the age of 10, wherein they start at the onset of puberty. Basically, you have to introduce the concept to them. Ano ba ang pagdadalaga at pagbinanata? So they would know what to expect. And maybe you can guide them through, or we can guide them through the process. So what will they expect? And because of this condition, ito yung mangyayari. So basically, it's important to be introduced to the team early. Siguro at 10 years old, it's a good time because it is the onset mostly often of puberty, because they will be comparing themselves to their counterparts. Bakit wala pa ako on breast development? Bakit si ate parang mas malaki sa akin yung ganyan? Pag di pa ako tumatangkad? You have so many questions. So basically, as early as possible, around 9 or 10, we can be introduced so we can address the concept age appropriately na we have the dahil nga sa condition na meron ako, ito yung nangyayari sa akin. So, as early as that. And regarding the concept of transition, when we say transition, this is actually the planned transfer of the health service of a child with chronic condition and their families from a child-oriented care to a adult-oriented care or adult-oriented service. Most often, without the transitioning model, ang nangyayari, they are lost to follow up. Because basically the experience is so bad that they really don't want to go back to the hospital system. So basically this transition was developed to gradually prepare both child or teenager and parent into the transfer to a different service. So basically that is why we introduced this model. So this could be introduced as early as 10 years old, or actually as early as 12 years old, so that they would be know at a certain age. You introduce actually the policy at this point. So when we talk of transition, it actually has 6 core elements that we have to introduce. First is the transition planning or the transition policy. That is basically, you can discuss the transition policy. This is early as age 12 to 14. Then actually go to transition tracking and monitoring, wherein you track the progress of disease. This is at age 10, 12, at 14 to 18. And also at 14 to 18, you actually do the transition readiness scale. That the assess a scale. So basically in PGH, what we do is we have a transition readiness scale. It is actually term transition. It is actually ask questions about the type of illness, the medications, the adherence, nutrition, self-management skills, and gauge what other information they need to prepare them for the transfer.
Okay,
Then
thank you, Dr.
after-
Marga. Let's stop there because there are so many important points that you mentioned, and I want for the audience to remember that, usually when you think of CAH, we only think of endocrine, and then if there's ambiguous genitalia, you think of the surgeon. But what we're hearing from Dr. Marga, we should not forget that they will become teenagers and eventually becoming adults. And in the process, there are a lot of psychosocial issues that must be addressed as early as 10 years old. So I'm really happy that Dr. Marga is emphasizing the importance of giving this kind of attention to the issues, not just medical, but the psychosocial component. Okay, so go ahead, Dr. Marga.
So I will go back to our transition to the core elements of transitioning. So I already mentioned the transition policy. You do this as early as 12 to 14. Then we go to the transition tracking and monitoring. We do this as early as 14 to 18. Also at 14 to 18, we actually have to do the transition readiness scale. I already mentioned some elements that we do. We talk about the type of illness, the medication, we talk about adherence, nutrition, self-management skills, issues of reproduction, trade in school, insurance, and also ongoing support, and also health providers. So what we do is we actually use the scale every 6 months to track the progress. So whatever portion of the scale that they score low on, we have to give them lectures, mini lectures, or we can engage them into a small group discussion with their other counterparts experiencing the same, so that we can talk to them about the issues that they are missing.
Okay,
Also,
we'll stop there, Dr. Mark, because I want
Okay.
to give the information to our audience by bites, so that we are able to bring in some messages. So the message that Dr. Mark is saying now is that transitioning is a process. It has to start early because there is a level of readiness. So we cannot always assume that they can be adults immediately. We cannot assume that they can just go to an adult clinic and just become adults with CAH. So the process happens as early as 12 to 14. Okay, so moving on, Dr. Marga.
So we give the transition readiness scale at the age range of 14 to 18. So we know what topics need to be discussed further. More often from my experience, they usually lack skills or knowledge on the reproductive health and also in insurance. That's why most often during our LK Lipat Kalinga sessions, we actually are involved more in teaching these teens what is sexuality mean and also reproductive health, because actually they rarely talk about this at home. So we actually are the first persons to tell them that they could actually get pregnant if they are not very careful. Other than that, so after you do the transition readiness scale and talk to them about these things that they need to talk about, at the age of 18 to 21, you do the actual transitioning to the adult healthcare. But before actually transitioning, they have to be introduced already to the other adult counterpart of the team so that they will be more familiar with them already. So important also to introduce the adult counterpart early in the team so they would know that eventually they will be transferred to this doctor so that they will get to know this doctor better. So at 18 to 21, we are already transferring to adult healthcare, and we are already starting to integrate in the adult practice. Then the actual confirmation of transfer or completion of transfer occurs at around 18 to 26. But during the time, they can still go back to our service if they actually need more information that they're uncomfortable with. So the process is still porous. You can still go back anytime they want so that we could also assist them in the process of transferring. So hopefully at the age of 18 to 21, they're more comfortable with talking about their own illness and already talking to their own doctor without the pediatrician or the parent already involved. Okay, hopefully through the process of transition, they're already ready by the time.
I guess that's if you heard the transition exercise, goes all the way to adulthood. And Dr. Marga was talking about, whether at the age of 21 to 26, whether they still need a pediatric adolescent doctor on board because of the long relationship, but then it is a process. So I guess, I've heard from you. So Dr. Babu, Dr. Sylvia, Am I correct? Most of them get pregnant and have children. Is that in your local experience? Do some of them get married and have children here in the Philippines?
Okay. Personally, I know of one or two of our patients who've gotten pregnant and delivered a successful pregnancy.
Mhm.
But literature says that 60 to 80% of CAH are actually fertile. The 60% would belong to those with the salt wasters. But the 80% who are fertile are those who are the non-salt wasting type of congenital adrenal hyperplasia. So yes, they can get pregnant, they are fertile, they can go through the same process. But what is the key? Continuous medication, monitoring for the appropriate dose, which is supposed to be age and weight related. So it's really the key, Doc mentioned, is really good control, good monitoring, good follow-up, and then of course the psychosocial support of family, friends, and the medical community.
And this is a lifetime management, Dr. Sylvia.
Yes.
So I mean, in most sessions I've been part of, they end with discussing the medical part. I'm really happy that today we're giving a focus on the psychosocial component, because these children grow up, and as you've heard, they get married, they go to work, and they can be part of society. And I think the emphasis always on the role of the family and the peers is important, not only at the beginning of the journey of a baby with CAH, and even as they enter the teens, they need the peers, and of course still the family and the doctors. And you can see that it's really a whole community trying to support the patient. So I have one, last question for Dr. Babu. And assuming you've had the diagnosis early in life with newborn screening, do they ever get into a crisis throughout their life and even adulthood?
Yes, it happens. And
When?
usually it is because sometimes early on, the parents themselves question the diagnosis, and then they withhold the medicine. And then they come to the hospital and you find out, oh, they didn't give it because they just wanted to be sure it was the right diagnosis. That's one. But also as they are beginning to grow up and become more independent, they start to challenge. What if I don't take this? Or sometimes, how our young teens are, preteens and adolescents, where they are but they cannot be bothered with having a condition. They don't want to be different. So let's say they go out, they party, they forget their medication. And if you will recall, when we discussed CAH in our last episode, we mentioned that it was critical that these children would really drink their medicines at the appropriate dose, and there is a timing. So if it's hydrocortisone, it's 3 or 4 times a day. If it's prednisone, it's twice a day. And some of them might forget the evening dose or the morning dose, and that can push them into a crisis. Missing medicines, having an infection, having trauma. Those are probably the most common that can push a child, an adolescent, an adult into an adrenal crisis.
Well, thank you. Thank you very much, Dr. Sylvia. Can we have some final messages from the group? Maybe I'll start with Dr. Marga.
So my final message to everyone will be, first and foremost, when we talk of a child or a teenager with CAH, it's always a team effort. So we have to engage your mental health expert or your adolescent medicine specialist early on, so that we'll be able to guide both parent and the child into the process. Because this whole management of this is always a process. But you have to guide them in the questions that they have, so that we will be able to prepare them for the next step, and the next step in their journey as their teen or their child with with CAH reaches first adolescence and later on adult, so that together we will take this journey, help them prepare for the next step in life.
Thank you, Dr. Marga. Dr. Sylvia,
Yes.
final message to our viewers.
So I think first and foremost, please recognize ambiguous or atypical genitalia at birth, and as soon as possible. Number two, when you recognize ambiguous genitalia, this is an emergency. You have to diagnose what is going on. Is this CAH or is it a disorder of sexual development? Number three, assemble your multidisciplinary team and continue the care from the neonatal period all the way till adolescence, because we are all in the pediatric age group, and then transfer them to the appropriate adult service. So that is my take-home message.
Kaya dapat magpa-newborn screening. Newborn screening.
Thank you very much to our panelists, Dr. Sylvia and Dr. Marga, for taking time out of your busy schedules to talk with us about the long-term management of congenital adrenal hyperplasia. Today, we appreciated that CAH is not only a medical condition, but entails several psychosocial and psychosexual concerns. Dr. Sylvia emphasized the urgency of making a final and correct diagnosis for babies with ambiguous genitalia. Dr. Marga clarified the role of the adolescent pediatrician in the life of a teenager with CAH as they assist the adolescent transition from adolescence to adulthood. Both Dr. Sylvia and Dr. Marga stressed the role of a multidisciplinary team. Thank you again, Dr. Sylvia and Dr. Marga. To our virtual audience, please send us your comments, questions, or the list of topics that you want us to cover in our succeeding episodes. Email us at info@newbornscreening.ph, or you may tweet us at newbornscreenph, or also include the hashtag #ENBSPH. Before we end, I want to take again this opportunity to present to you the new addition to our tools in learning, our ENBS mobile app. The ENBS mobile app is a one-stop hub for all MBS health workers on everything they need to know about newborn screening. It also features a rewards program that our health workers can use to earn points and use it to claim shop vouchers with our partners. If you have already downloaded the app, answer the quiz that we will send to your inbox to earn those points. We continue to improve our services as deemed necessary by the emerging challenges through an open dialogue about our experiences in newborn screening. It is our hope that through this program, we extend the sharing of knowledge with greater reach, empower our frontliners, improve connectivity with newborn screening coordinators, and most importantly, provide unparalleled service to every family. Next week, we will discuss a metabolic disorder included in the ENBS panel. This and more here in Newborn Screening in Focus. Nothing is more precious than seeing a child grow healthy and normal. Let's realize this through newborn screening. Newborn screening is a gift of life.
Mula sa sinapupunan, 9 na buwan ka naming inalagaan, at ngayon nandito ka na, di ka namin pababayaan. Oh, aming baby, isa kang blessing, kaya dapat magpa-newborn screening. Oh, aming baby, isa kang blessing, kaya dapat magpa-newborn screening. Love na love ka namin, kaya ito gagawin. Para sa kalusugan mo, dapat natin tong sundin. Oh, aming baby, isa kang blessing, kaya dapat magpa-newborn screening. Oh, aming baby, isa kang blessing, kaya dapat magpa-newborn screening.
Napakadali ng process na magpa-NBS. Ilang patak ng dugo ang kailangan para magawa ang test. Makalipas ang 24 oras pag si baby lumabas, gawin natin ng NBS, alin sunod sa batas.
Oh, aming baby, isa kang blessing, kaya dapat magpa-newborn screening. Oh, aming baby, isa kang blessing, kaya dapat magpa-newborn screening. Newborn screening. Newborn screening. Oh, aming baby. Newborn screening. Para sa iyo rin to, sa kalusugan mo.